Today, the topic is retinopathy of prematurity, clinical importance of infrared lasers. And we do have two speakers today, Dr. Consuelo Zepeda from Guadalajara and Dr. Marco Ramirez from Mexico City. The outline of the presentation today will be in two parts. The first section will be an introduction by Dr. Ramirez, including a clinical background of what is ROP. He'll talk about his experience using the LIGHTLas 810 infrared laser for ROP, including parameters that he suggests, and his experience using the LIGHTLas 810, including training tips and past seminars that he's done in training some of his colleagues. The second part of the session will include an introduction by Dr. Zepeda, a deeper clinical understanding, and why lasers are so important in the applications of ROP today. She will support these claims with case reports and finally draw some conclusions to close the session. At the very end, we will have a question and answer session being answered by both Dr. Zepeda and Dr. Ramirez. Now it is my pleasure to introduce Dr. Ramirez. Thank you very much.
Okay, let's get started. My name is Marco Ramirez from Mexico City, and I am very pleased to participate in this very nice webinar about the clinical importance of infrared lasers on ROP. I'm head of department and professor of pediatric ophthalmology in Hospital Infantil de Mexico in Mexico City. And I'll be very happy to share with you my experience using LIGHTLas on ROP treatment. These are the topics we will talk during the presentation. We will talk about preoperative preparation, laser settings and parameters, intraoperative suggestions, and some tips during the surgery, and how to train residents, fellows, and ophthalmologists for retinal laser photocoagulation. Well, first of all, ROP treatment is an emergency and should start as soon as possible. If you have a patient with aggressive posterior ROP, the treatment should be done within the first 48 hours. If you have a type 1 ROP, should start within the first 72 hours and should be carried out in a clean, temperature-controlled environment to reduce risk of hypothermia, infection, and apnea. This is our hospital operating room with our pediatric anesthesiologist preparing the bed of the patient, maybe 30 minutes before the patient arrives into the operating room with her resident. Pupil dilation is also very important, should be done in advance with 1% tropicamide and 2.5 phenylephrine, 2 drops every 10 minutes, 30 minutes before procedure starts. You can also use cyclopentolate eye drops. And if you have a patient with difficulties in pupil dilation, you can use a short course of steroids and cycloplegic prior attempting laser treatment. And here you can see a patient I treated 15 days ago with neovascularization of iris with some vessel over the anterior surface of the lens. Very difficult, but we treated successfully. Fasting is also very important. We have two options. If you use local anesthesia, the patient should not receive food 1 hour or 2 hours before the procedure. And if you use general anesthesia, the patient may need to fast up to 6 hours prior treatment. It's kind of controversial to talk about type of anesthesia, but in my hospital experience these decisions is on the anesthesiologist along with neonatologists. We as ophthalmologists, we never make that choice. Here you can see my two residents performing laser. One of them is surgical assistant, and she's wearing protective goggles, and she's also helping with corneal hydration. You can see here the thermal mattress to stabilize the patient's temperature, and the surgeon performing laser. Now we will talk about laser parameters and settings. First is power. Is depends on the skin color of the patient, because pigment is very important. For example, in Latino patients, dark color of skin and retinal pigmented epithelium is darker than Caucasians. Maybe you can start using 100, 150. And in Caucasian patients or Slavic patients, you need to increase the power. The goal is to produce grayish white burns, avoiding white burns like this one. Here you can see the lasers burns. And for example, this one was my first, and it's very white. You should avoid this kind of color. And the goal is to produce grayish spots like in this area of the retina. Should be confluent laser burns in all the avascular area. Duration. Duration could be between 150 to 100 or maybe 300 milliseconds. And that depends on corneal clarity and burn color. But you should be very careful, because if you use a high laser power with pulse duration long, for example, in this one, you can produce choroidal rupture, and that is very dangerous. My advice is to make some test burns before you proceed to make the rest of the laser burns. The interval. The interval means the space between each laser burn, and my advice with my residents is to start slow, maybe 700, 800 or 1 second interval. And when you find a very nice place for a starting procedure, you can change the interval to a faster rate, for example, 200 or 300. But my advice is not to have a faster than 200 milliseconds, because the burn cannot be effective. Here is the LIGHTLas screen. Here is the interval part of the screen. And you can see here 0.5 seconds. That means 2 laser burns every second. And you can put it in a fast mode, for example, 0.3 seconds, 0.2, when you are comfortable with the view. Spot diameter. This is a very nice LIGHTLas feature, because we can change the size of the burn. And you can change it to a bigger size. You can see here in this slide with this part of the indirect ophthalmoscope, which we can start 300 diameter, but at the periphery you can use it 500 microns spot. It's very nice, because you will need less spots at the periphery, and you can do a faster procedure. Now it's a very important question. Why is more advisable to treat ROP patients with A10 infrared laser rather than a green laser? And the answer is because laser light absorption, hemoglobin, is a very important part of the eye, and green and yellow lasers absorb more laser light than infrared. So here in this graph, you can see how this green wavelength is more absorbed by hemoglobin or oxyhemoglobin compared with A10. A10 is less absorbed, both hemoglobin and oxyhemoglobin. And this is very important because sometimes, as my previous slide, you can see some vessels on the lens anterior surface, and you can produce iatrogenic cataracts because the hemoglobin is going to absorb more the green laser wavelength. Now I'm going to talk about laser photocoagulation tips. My first advice is to arrive in the operating room maybe 30 minutes before the patient to prepare the area the surgeon is going to use. And I always tell my residents to clear the area at the top of the bed, the place where the baby's head is going to be placed. And this area I'm pointed with the arrow should be clear because you will move from one place to the other looking for a vascular retina in the patient's eye. Also, it's very, very important to use the proper eyelid speculum for premature babies. For example, this one is Cook eyelid speculum of this Alfonso eyelid speculum. It's very nice. It's also very nice tip to use some soft steroid eye drops during procedure with limited penetration in the cornea to decrease corneal edema because we will use a very powerful light from the indirect ophthalmoscope, and this can cause some corneal inflammation. And it's also advisable not to use excess of irrigation because this also can produce corneal edema. I already talked about this, changing to a large spot size during the treatment of periphery of the retina to minimize the number of shots and decrease the surgical time. Here's my resident making some adjustments in the indirect ophthalmoscope. And during the laser treatment, the surgeon should take advantage of his or her position to decrease surgical time. What I do is to place myself in the left, at the left part of the baby's head. And in this position, I can treat the left eye nasal retina for 10 minutes, and then to shift the eyelid speculum to the right eye, and I can treat the right eye temporal retina at the same time with my same position. And when I finish this, after 10 minutes, I can move myself to the other side to treat the left eye temporal retina for 10 minutes and the right eye nasal retina. This is what I talked before. The treatment may be applied first to one eye for 10 minutes and then to move the treatment to the other eye to decrease corneal exposure. And it's very important to make the treatment as short as possible to decrease the risk of complications. This is an aggressive posterior ROP, a very, very difficult patient. And my question to the audience is, how many burns do you think we may use for this patient? It's difficult to say, but maybe up to 2,000 burns we may need to use in each eye, and we need to make it very, very short and very effective. Now I'm going to talk about how to train residents and ophthalmologists on laser treatment. I should say that it was Dr. Zepeda's initiative. In 2019, we organized, under the leadership of Dr. Consuelo Zepeda, our first theoretical and practical seminar on laser photocoagulation with indirect ophthalmoscope using sedated rabbits. It was very cool, and I will explain how we did it. Before the laser practice, we give a lecture on basic principles on laser surgery for retinal diseases, very similar to this one. And then we moved to the practice. We were 3 professors, instructors, who gave attendants personalized training on this LIGHTLas 810. Here you can see Dr. Zepeda showing the people here how to use the laser with this sedated rabbit. Here you can see veterinarians taking care of the animal. All the rabbits were cared on the local animal protection laws, and all of them, all the rabbits, were supervised by 5 veterinarians during the whole session. I must tell you that all the rabbits weren't harmed in their eyes or life after laser procedure. We trained 15 certified ophthalmologists during this seminar and 5 pediatric ophthalmologist fellows. All of them performed laser surgery for about 15 minutes, along with the instructors who guided them during the whole procedure. Here you can see, I think we had 4 tables with this equipment and instructors. And my final conclusions are: currently, indirect ophthalmoscope laser photocoagulation remains the gold standard for ROP treatment. Intravitreal anti-VEGF injections are very cool, have a very therapeutic potential. However, we don't know the ideal dose, ideal stage for administering this drug, and it's going to be determined in the near future. Laser photocoagulation will remain as a crucial tool both for first-line ROP treatment and recurrences after intravitreal injections. Thank you very much for your attention.
Good morning, everybody. It's a pleasure to be here. I'm Consuelo Zepeda, pediatric ophthalmologist with a special clinical interest in avoidable childhood blindness and ROP. I founded the neonatal ophthalmology clinic at Hospital Civil de Guadalajara, where I work. I'm member of the Mexican Academy of Pediatrics and the international member of APOS. As you know, retinopathy of prematurity, the main problem is an ischemic avascular area. Is how many babies are born, and once they are born, they get too much oxygen, and the retina first stops the development, but at the second point, the development is completely sick, and they produce quite abnormal vessels, and these vessels can grow that much and leak that much that could detach the retina. So far, we have avascular areas or ischemic areas. We will have problems that's in acute phase or in a long-term phase. Which options we have to treat ROP? During the 80s, we used cryotherapy. This was to reduce these growth factors that develop during ischemia, the vasoendothelial growth factor. During the 90s, we used laser. This was to reduce the amount of retina that was producing these growth factors, the avascular retina. And 2010, a little bit before, we had access to anti-angiogenic agents to reduce the amount of growth factors. For many, many years, laser was the monotherapy is still the gold standard to treat ROP. Unfortunately, anti-VEGF cannot be used as a monotherapy for many cases because the long-term risk that these eyes have. So if we could talk about the options we have now to treat these babies, we need to talk about laser, and we need to talk about anti-angiogenic factors that could help the retina, but for many cases cannot be an option for monotherapy. Laser is the gold standard, and anti-VEGF arrived to stay, are part of the armamentarium. They stop the disease. They really stop the disease for a while, but it's not the cure. We need to have special considerations for aggressive posterior ROP cases. For acute phase ROP, yes, it works. But for many cases, we have problems for the long-term stability, and we do have potential systemic effects. Children that have been assessed for vascular leakage with fluorescein angiography, they have found that after aggressive posterior ROP, and after this treatment, they still have vascular arrest and avascular zones with leakage after 1-2 doses of anti-VEGF. So they need to be treated in these areas. If not, they will have a late retinal detachment. As we know, children that have received bevacizumab for zone 1 and zone 2, Avastin induced regression mainly in those children with zone 2, but not for the children in zone 1. Those children stay with vascular abnormalities at the periphery, and they need to receive laser to treat these abnormalities and prevent a late retinal detachment. Children have been followed, children at age 4, those that receive bevacizumab, and they have found that all these children that were treated for type 1 acute ROP have avascular areas, leakage, chance, and hyperfluorescent lesions. So these children need to receive laser to consolidate these abnormalities in the periphery and to avoid a late retinal detachment. We know that many children that didn't reach type 1 ROP, those that were with type 2, and sometimes they have a spontaneous regression, some of these children, they still have vascular abnormalities in the periphery. So we need to identify them and to treat them with laser. Here are some examples, like those hyperfluorescent areas, you cannot leave them like that. And this ischemic area maybe is not giving problems at the short term, but for the long-term follow-up, you cannot leave them like this because we give this patient a late retinal detachment. Here are these hyperfluorescent areas after receiving anti-VEGF and these neovascular tubs. So here is clear that even sometimes you consider this normal, it's not normal because this ischemic is producing neovascular tubs. So we need to consolidate these areas with laser. We know that to prevent associated late ROP reactivation and then retinal detachment, we need to treat the residual avascular retina around week 60 of postmenstrual age. We need to recognize that ROP is a lifelong disease. It's not only the acute phase of ROP. When we are treating the baby until is discharged or until the week 50, ROP is a lifelong disease. We need to follow these patients. We know that we have persistent avascular retina in children that didn't reach type 1. We're talking those children that develop stage 1, stage 2 without plus disease. So 5% of these children have ischemia, avascular retina, and some of them really need to be treated. If not, they will have a retinal detachment somewhere. When to use LIGHTMED, LIGHTLas 810. In every case, we need to use laser. Laser is the gold standard to treat ROP. Anti-VEGFs are part of the armamentarium, but for many, many cases, cannot be used as ROP monotherapy. Anti-VEGF stops the disease for a while, but is not the cure of the disease. We need to talk about long-term stability in these cases. As you know, those cases that are extremely advanced, when they are recognized, we cannot use anti-VEGF. We have the risk of a crunch phenomenon. We need to use laser, sometimes 360 degrees around. And before using the laser, we need to consider some anatomical issues, as it is the 3 and 9 meridian because of the long ciliary arteries. And we need to identify exactly where we will place the laser, the avascular or leakage zone. And we need to avoid ora serrata and ciliary body. So as we were talking, advanced cases need to be treated with laser. They cannot receive anti-VEGF. And all those cases, sometimes they receive posterior laser, posterior to the ridge, 1 or 2, even 3 rows of laser. This is controversial. Some persons think this is normal retina. Many fluorescein angiography studies have shown that this area is ischemic as well. So they receive laser because they should not be treated. They should not be treated with anti-VEGF. Laser as a monotherapy is a very good option for many, many cases, or could be combined with anti-VEGF. If we have persistence of plus disease, we need to consolidate those cases. And in cases where they already received laser, we should complete the area that was not treated. Here is this patient treated in 2 different times. For those children that receive anti-VEGF, for many, we have persistent avascular zone, and at week 50, 60, we need to treat them. Most of them, they need general anesthesia, and we need to consolidate this area to avoid late recurrence and late retinal detachment. Those children that already received 1 or 2 injections of anti-VEGF and we are still getting reactivation, we need to consolidate them with laser. A third injection won't give any change. And those children that have clear recurrence, even if they don't have plus disease, we need to consolidate them with laser. Here's the fluorescein angiography of the same patient. I will not discuss about the role of anti-VEGF in aggressive posterior ROP. I think it's a very, very good option to let these small areas develop a little bit more, and those vessels to reach zone 2 or sometimes zone 3. But all these children will need to be followed and to identify if they have avascular areas, some residual avascular zones that need to be treated and consolidated with laser. It's a very nice option to treat these children, but we cannot leave these areas without treatment because they will then have a late retinal detachment. So, LIGHTLas to treat ROP is a very good option in advanced cases because of the risk of crunch phenomenon when using anti-VEGF agents, to treat ROP recurrences after anti-VEGF, to treat incomplete laser ablations, and to treat those areas that are avascular and exudative despite the use of anti-VEGF. We need to use laser for those avascular areas during vitrectomy as well, and is the first line option and the gold standard to treat ROP when we need to avoid potential secondary effects of anti-VEGF agents. It has been reported neurological and cardiovascular secondary effect of these agents. Thank you very much for your attention.
Perfect. Thank you.